Hello and welcome to Chapter 16 lecture from the Lever Dermatopathology series that we're doing here at CTA Lab. This is a kind of esoteric subject, but it's quite important, especially to the dermatology residents and to dermatologists that are working in tertiary care centers. So I got to say, in our practice, since we're not affiliated with a tertiary care hospital or a children's hospital, we have less experience with these diseases, but there's something we talk about in our training, and there's something, that is ever present at meetings. So I hope to teach you a little bit about that today. So to get started, and one thing also, because the subject is esoteric, we don't have, I'm not going to have unknown slides for you, and we'll just give the lecture today. So some really big concepts in nutritional deficiency histopathology is that the histologic features are often very subtle, and they're often very non-specific. So what we do in not just dermatopathology, but all of pathology, is we often make the diagnosis not just by looking through the microscope, but with also the clinical correlation, the presentation. And so you have to really take that into account in these cases. So it's one of those things, in the context of what we're looking at, we can make more specific diagnoses. But one super big concept to think about is pallor of the superficial layers of the epidermis. And this has often been called ballooning degeneration, but you lose the granular layer. And if you just kind of absorb this histopathologic feature, and then as we get into more of the details of the entities, you'll see that it has a wide application. And this goes right into number 2 here of the big concepts. More than one deficiency can look the same. So a biopsy from 2 of these different deficiency dermatitis can have almost essentially the same histologic appearance. And then just for deficiencies, just think broadly across what can cause a vitamin deficiency, and the things we see in order of importance, or how the common things we see. Alcoholism causes a number of deficiencies, and then any kind of GI disease, whether it's cystic fibrosis, has to do something with surgery, barometric surgery, and then we have all these diets, weird diets, both in children and in adults. You have the tertiary care centers, a lot of people getting parenteral nutrition, eating disorders, and then you have things like liver transplants and other things can cause these same problems. So moving on, I want to start with vitamin C, or ascorbic acid deficiency, first. And if we just step back and say, what does vitamin C do? It's important in the formation of collagen, or protein construction. And then you can just extend that to say hair shafts are made of protein. So whether it's a collagen fiber or the protein comprising a hair shaft, it's important in construction of both. And what you can see here is that it causes 2 problems, and this will lead to the features that we see histologically. So in collagen formation, we see hemorrhage, and this is because the vessels of the vessel walls are made of collagen fibers, and they rupture easily when the collagen is not formed. So poor healing also is a part of this, but just think of hemorrhage, and it's not just in the skin, but anywhere. So you can have it into joints, you can have it, in the mouth, different places you'll get weak vessels. And then there's also this classic woody, hard lower extremity edema of scurvy, which I've never seen clinically, but this is probably also because of very weak lymphatic walls. So just think of poorly formed vessels. And then the second is the hair growth. And what we see with disordered or messed up hair growth is follicular hyperkeratosis is a common feature. And then the classic corkscrew hair in vitamin C is important. So here's a picture I pulled off the web of corkscrew hair. So you wouldn't think that we would see scurvy in the developed world, but we still do. And this can be diets in children when parents are giving alternative formulas, or they can be even diets in adolescents that have very poor diets. You know, there are reports where somebody only ate cookies as the primary source of calories and end up with this. But just remember, vitamin C isn't stored in the body, and so you can still see it. So the histopathology, we didn't have a single example in the last 24 months that I could find in our scanned system. So I pulled this from the Whedon book, but it has the two features we were talking about. And here is the follicular, a dilated follicular ostium, and then you can see an altered hair follicle right here. See, it's asymmetric. Right here, a few inflammatory cells, and then this isn't a great photomicrograph, but these are extravasated reds. So you see the hemorrhage here, and then the altered hair follicle, and those are the two features, non-specific, but that's what we have. So here is an example of Keratosis pilaris, and in a lot of these entities we're going to look at follicular hyperkeratosis, or is a feature of the deficiency. And this is an example of Keratosis pilaris that we had in our system, and you could see how this could very well be scurvy. Look, you have a corkscrew hair. This is all the same hair shaft, which is exiting and it's no longer straight. And then you have dilated ostia, and then we don't see the extravasated reds here, but you could. Here's the example where Whedon is trying to show the same thing, and you see the hemorrhage nicer on this. And here is an example from that I found online, and they're trying to show the corkscrew hair here, but you can see how similar this is to our example of Keratosis pilaris. So the bottom line is the histopathology is not specific, but it can help get you there. Notice in this example of the scurvy how much more extravasated reds there are, and it's probably true that there is a little more extravasation around follicles because there are more venules around the follicles. So vitamin A deficiency or Phrynoderma is our next entity. This is a very rare entity, and I want you to think about not just deficiency, but we also have toxicity. So in deficiency, you have dry scaly, which is a commonality in vitamin deficiencies, but it's dry scaly eczematous lesions, and then you also see folliculocentric hyperkeratotic papules, just like we saw in the vitamin C. And then all important is the ocular findings, which I won't get into today. Toxicity, also have dry skin in this. Colitis is the other one. So there's three things: dry skin, colitis, and then patchy. It says patchy alopecia, but it's actually fairly diffuse. I've never actually seen a case of it. And then once again, the histopathology will be hyperkeratosis with Keratosis pilaris-like plugging. So moving on to niacin, nicotinic acid deficiency, or Pellagra. This is the 4 Ds. Everyone says, oh, it's the 3 Ds plus the 4th D. So diarrhea, dementia, and dermatitis. And then the 4th D is always death if it's not treated. The clinical presentation is, the classic is burning erythema in sun-exposed areas that leads to blistering and then to hyperpigmentation. And one of the features clinically is the sharp margination of the erythema. You also have the classic glossitis, angular cheilitis, fulvitis, so you can have different things. One thing to remember in niacin deficiency, which is on the handout, is that a number of drugs can cause this: chemotherapeutic agents, anticonvulsants. There's case reports I found of people being treated for seizures that get this, some of the anti-tuberculosis meds. There's a long list that you probably should take a look at. The other entity that falls into the niacin deficiency group is when there's a problem with tryptophan metabolism. So carcinoid syndrome can mess up the tryptophan metabolism and produce this rash, and also heart nut disease, which we won't get into terribly. Congenital disease can also produce this. So the histopathology of niacin is really what I was talking about at the first, where you get this hyperkeratosis, parakeratosis with loss of the granular layer. So we always think of loss of the granular layer in psoriasis. So if you were to really make a big mistake and look for common things, this could potentially be called psoriasis, but this will have more of this, what I was calling the ballooning degeneration. And these are pictures from the Whedon book, which aren't terribly high quality, but this ballooning degeneration is supposedly right in here, where you see sort of larger keratinocytes. But the big point is there's no more granular layer. You once again have follicular plugging in this, which is a milder feature, but keratosis pilaris-like. And then as this progresses, you can the epidermis kind of starts falling apart, and you can get intraepidermal bully, subepidermal bully, full thickness. Necrosis is a possibility, but this is not the same kind of process as an immunobullous disease would cause. This is more a degenerative bullous process. There's publications alleging that sebaceous gland hyperplasia is also a feature of this, but I'm not personally convinced of that. Just a few esoteric things. Vitamin K, just in the deficiency world, we think more of the really only thing from a histopathologic importance is that the injection site of vitamin K's can have reactions, and they're often kind of urticarial or dermal hypersensitivity in their nature with lots of EOs. There's some where you get a kind of sclerodermoid-like reaction at the site also. That's just something you should probably know about. So I have vitamin B12 left, just a couple things to catch up on here. Protein deficiency, we do see this around because we see people on low protein diets, and that's once again xerosis. Dry skin is a theme here. Hypopigmentation, peripheral edema, of course, kwashiorkor, and then thin hair. And I do, as a alopecia expert, I see a lot of thin hair from protein deficiency. If we group riboflavin, let me just pull this over really quick. This is on the handout. If we group riboflavin and peroxidine deficiency together, it still, once again, has the glossitis, stomatitis, like we see the chelosis. And then, but important to know about is the subderm-like eruption with these, so seborrheic dermatitis like eruption. And then just a little board or just a little detail here is the riboflavin deficiency. Often the rash is on the scrotum. So if we go to vitamin B12, the big thing here is poikiloderma. So here in this publication from an Indian journal, you can see this is what, so there's not just, so poikiloderma is a mottled pigmentation. So you have areas of hypo and hyper, and you might have some erythema, but the poikiloderma is describing just this variability in color. And what you see with vitamin B12 is hypo, but you also see supposedly some areas of hyper. And Whedon describes this as caused by increased pigmentation along the basalis, which I'm not entirely sure of that, but you certainly have a lot of melanophages show up, and this causes the dyspigmentation. And just a point, we call this post-inflammatory pigmentary alteration. PIPA is the common term we use, and that's because some people get darker and some people get lighter when they spill their melanin from their epidermis into the dermis. And a lot of darker skinned people will get lighter, and then lighter skinned people will sometimes get darker. So this is one of the features of vitamin B12 deficiency. One of the things in our community you should know about is nitrous oxide abuse can produce this, and it has something to do with the metabolism of the nitrous oxide molecule uses up B12, and so chronic use can cause the deficiency. So in the next group I want to go to is necrolytic erythemas. And I just want to point out, I took we take the subjects of these lectures from the Lever book, but I organized this a little bit more around the Whedon book. And the Whedon book is just, we decided it was too much for this lecture series, but it isn't a bad source for learning. So I'm grouping under necrolytic erythemas, acrodermatitis, enteropathica, number 1, Glucagonoma Syndrome, number 2, and necrolytic acral erythema, number 3. So this is the first of what we're going to call necrolytic erythemas, and they have this similar histopathology. So once again, this theme that these deficiency dermatitis have similar histopathologic findings. So in acrodermatitis enteropathica, rare, autosomal dominant, zinc transport, can see zinc deficiency for other reasons, but the triad here is alopecia, diarrhea, and dermatitis. And the dermatitis is periorificial and acral, described as chronic eczematous, can be bullous or pustular. And then you get secondary infection on top of it. Nail and hair involvement, obviously the alopecia, and depigmentation once again. So there are mimickers of this, and this is board information. It's in the handout. Amino acidopathies, the methylmalonic and propionic, acidemia, selenium and biotin deficiency is a mimicker, and there's a rare genetic, the glutamine synthetase, the GLUL gene mutation. So histopathology, just to remember, and I put this in red in the handout, it varies with the age of the lesion. So keep that in mind, and that's true with a lot of things in DermPath, but in these it's important. So biopsying early is going to look different later. What you see is, and this is the commonality similar to what we saw, I've already seen here. We see loss of the granular layer, not so much of that ballooning up, which I don't think I really showed you really well, but loss of the granular layer and then confluent parakeratosis. So I would think quickly, oh, could this be psoriasis? Because psoriasis, you lose the granular layer and confluent parakeratosis, but it's different. We see a thicker parakeratosis, layer of parakeratosis here than the epidermis, and psoriasis usually is psoriasiform, or you get marked acanthosis. But as these lesions continue to exist, they change and you get more. So here you can see it's looking a little more psoriasiform, and the point here from the Whedon was you started to get neutrophils. And this may be secondary infection, so this could make it hard to tell from psoriasis. So if you're looking for a deficiency, especially one of these necrolytic erythemas, and you get a diagnosis back of psoriasis, you need to pick up the phone and call the pathologist and have a discussion and about whether this could be a deficiency. So pallor of the epidermis, confluent parakeratosis, and then as you get more involvement, you can start to see necrosis of the epidermis, and that's what these necrotic keratinocytes are. So we like to talk about necrotic keratinocytes when there's an interface dermatitis, but if there's an interface, you're having immune attack here along the basalis, and this is where the keratinocytes die, and then they move up. They move up as you as the epidermis turns over. Whereas in this, they're dying more superficially. You would want to give a thought to herpetic dermatitis. If you're near herpetic dermatitis and not right on it, you can see these little apoptotic bodies. But this is just a sign that the epidermis is dying. And here you can see a more pink coming down, and that you're starting to get more full thickness necrosis. Well, this necrosis can lead to bulla again. You can get confluent necrosis, and similar to what I showed you with the niacin deficiency, you can see clefts and bully at different levels, and it's just a degeneration. And then once again, keep in mind that these can be secondarily infected with neutrophils, which can make it difficult to distinguish from psoriasis. So in the notes that I gave you, the histopathology there in the red, I just wanted you to memorize that because it's important for all of these. It's the common histopathologic feature. So Glucagonoma syndrome, the clinical features are necrolytic migratory erythema, glossitis, stomatitis again, we saw this, the diabetes mellitus, glucose intolerance, brittle nails, anemia, weight loss, thrombosis. And these are usually from glucagon secreting islet cell tumors, but there's a lot of it around. It's described in other GI tumors, other proliferations of these islet cells that aren't really considered to be a tumor. So you can still get glucagon from other sources that isn't one of these islet cell tumors. Keep that in mind, that it could be a little more complicated. And then it's important to know about the pseudo-glucagonoma syndrome, where it's not this, and a lot of different things can cause this. Inflammation in the bowel, pancreatitis, drug use, heroin has been reported. Odontogenic abscess has been associated with it, and there's some treatments, the gefitinib, I don't know how you say it, therapy for non-small cell lung cancer has been reported to cause this. The necrolytic migratory erythema is important to talk about. These necrolytic terms are quite confusing. So in the past few minutes, I've thrown out necrolytic erythema, necrolytic migratory erythema, and then we're going to talk about necrolytic acral erythema. It's important to pause, spend a little time distinguishing this because they're entirely different things. So necrolytic erythema is the group of 3 entities, the Acrodermatitis enteropathica, Glucagonoma syndrome, and then the necrolytic acral erythema. So this is the group. Then the necrolytic migratory erythema is the clinical entity that I'm about to talk about that we can see in the Glucagonoma syndrome, and then this is an entity unto itself. So necrolytic migratory erythema is TEN-like, they're annular. It's annular erythema, often on the trunk, groin, thigh, sites of trauma, and it's described as waves of extending annular or circinate erythema with bulla and shedding. So this could be very much confused with TEN or other annular eruptions, and that's what you need to, this is one time a biopsy might be helpful. So histopathology, once again, glucagonoma, I'm just going to say it again, it depends on when you biopsy the lesion. So if you biopsy a very early lesion, you're going to see just the loss of the granular layer and some perikeratosis. And as they get more advanced, you're going to advance up to necrosis. And it's exactly like the Acrodermatitis enteropathica. So necrolytic acral erythema, I've never seen this. Very much over time has been associated with hepatitis C infection. Some studies have questioned this association, and I found one where they only found 2% of the cases out of like 300 reported that had this association. So there's kind of been a move to back off of saying necrolytic acral erythema as a sign that somebody has hepatitis C. Has been associated in some reports with zinc deficiency, and some observations also that it gets better when you give zinc. Of course, I question whether when you're giving zinc, you're also giving other nutrition. You're also making the person healthier. There's other things going on, so it may not be a direct result of the zinc. So this is just eroded erythematous patches, blisters, usually on the lower extremities, but it's an acral thing. And then the biopsy showed the same histopathology of the other acral erythemas. So Crohn's and ulcerative colitis were grouped together in the liver chapter. They're actually entirely different diseases, and they have different histopathology. So ulcerative colitis is more associated with secondary reactions and not direct involvement. And Crohn's disease, which is granulomatous, is more associated with what they call metastatic Crohn's disease, when you get involvement of the skin near the GI tract. So it's usually perianal, perioral, but it can be at the site of colostomies. It can be if the GI tract gets near the skin for other reasons, it can show up. So it's always kind of lurking, and it's one of those things that we see in unknown sessions. But just remember, ulcerative colitis at its core is more of a neutrophil associated entity. Erythema nodosum, which I talked about in my last lecture, I view this more as a pattern rather than an entity to itself. It does have a granulomatous, a neutrophilic component early and then becomes granulomatous. And you can see this also in Crohn's. And there's more vasculitis of different types associated with ulcerative colitis. Important to remember with the Crohn's, when you have perianal involvement, there are these giant tags which have been called elephant ear tags, and they're often mistaken clinically for condylomata. And it's important to they are not HPV related, they're just the Crohn's. And a biopsy of these will show right here granulomatous process. So it is helpful to biopsy for metastatic Crohn's. If you are contemplating this diagnosis, the patients usually have a history of Crohn's. It's a more severe in patients with more severe Crohn's, so that helps a lot. Biopsies of these entities with ulcerative colitis are often not as clear because they don't point. A diagnosis of vasculitis doesn't point to ulcerative colitis, or a biopsy of erythema nodosum doesn't point to ulcerative colitis. So I wanted to say something about aphthous ulcers. They this is actually was a more, I had typed this underwhelming histopathology, and then this is what I found in the DermNet New Zealand site, which has much more inflammation. But just keep in mind, it's a non-specific, generally superficial ulcer. Also lives of lesions, depending on when you biopsy it, there's going to be more fibrin on the surface. And it's also depending on the timing of it. It's mostly useful, a biopsy, for ruling out things, and namely herpetic dermatitis, any kind of HSV is, or varicella is important. You can do get hand, foot, and mouth sometimes. Anything that could be an interface dermatitis that's producing an ulcer. So say you had oral involvement of lupus, you have the interface, and then you have ulceration. So this could be, if you can get away from the ulcer and biopsy the edge, you might be able to identify an interface dermatitis causing it. Certainly neoplasms, metastatic Crohn's, as we already talked about. And then there are other non-biopsy tests that might be considered if you're seeing these lesions. Rule out syphilis, and then also ruling out immunobullous diseases. So that's it. The other things that were in the liver chapter, I wanted to mention that they talked a lot about the bowel-associated dermatosis arthritis syndrome, the bowel bypass syndrome. I think this was thrown in because they were trying to group GI, gastrointestinal disease, and dermatitis together. Generally, I put this back into the neutrophilic dermatoses with Sweet syndrome. So just know, histopathologically, this can be identical to Sweet's syndrome, and you have to have the clinical correlation. We talked about the aphthosis, and I won't get into the specifics of Behçet's disease. And then they also put Giannotti-Crosti syndrome, papular acrodermatitis in this chapter also. I tend to think about this as more associated with viral infections, but non-relapsing, symmetrical, rash 3 weeks, face and limbs. Histopathology is not specific, shows variable amounts of spongiosis, and tends to be a lymphocytic infiltrate. So that's about it for today. One last point I wanted to make. We didn't want to, I didn't have unknowns to show you, but when I was pulling up this Keratosis pilaris case that we have in our scan, I wanted to impress on you that when you're biopsying something that's very small, so the small things we think about are anything follicular, folliculitis, keratosis pilaris, any small bumps, so dermatitis herpetiformis, scabies, they're very small. You want to have the lab process this very carefully, because you can see here, this is an outside slide. It was not bisected, and I'm showing you the level slide here. But you can even see on these levels, see how there's no keratosis pilaris on this piece of tissue at all. It looks just like normal, slightly sun-damaged tissue. And then you start to see a little bit of follicular epithelium, but certainly can't say anything. And out of all the levels on this biopsy, through the entire tissue block, this was the only one that showed the keratosis pilaris. So it's important to do two things. One, the lab needs to be bisecting these when they're this big, because you can see here we have a 4 millimeter punch was performed, 3.78, and it was not bisected. And then also, if the lab really knows what they're doing, they'll bisect it through the bump. So if you have the folliculitis or the keratosis pilaris right in the middle of your punch or wherever it is, a good lab will slice right through that. And then the very first sections you see will have it. And then the second thing you want to get levels on the very first slides, because every time you cut these slides, some of the tissue goes into the trash can, the blade cuts, and then we save some of them to put on the slide, but not all of them. So this is an important point. Just think about when you're biopsying small things, what needs to be done. And one thing you can do in defense, if your lab isn't going to bisect it, is you can do the punch and then you can bisect it right through the middle of the what you feel needs to be seen, and then put instructions to not bisect further and embed, cut surfaces down. You can even ink those surfaces that you just cut, a tiny bit of ink, and say embed ink surfaces down. So there's a lot you can do. And this is also useful for porokeratosis, where you get the really small, parakeratotic columns, and you want to see those, so you can cut right through it at 90 degrees and then submit it to the lab and ask for the sections. So that's just a functional point that'll make your clinical practice easier. So that's all. My email is on the top of the handout today if you have any questions. If anyone has any good examples of any of these, I would appreciate a class slide or a picture or whatever. We would like better quality photos of these uncommon disorders. Thank you very much, and stay safe.